So with that, today we have Dr. Roberto Colon, who is the Vice President of Quality and Patient Safety at Premier Health and the Associate Chief Medical Officer for Miami Valley Hospital. First up, I just want to say thank you to Premier Health for being a longtime member of the Chamber and continuing to invest in our community. And with that, I'm going to hand it over to Dr. Colon, who's going to walk us through COVID-19's timeline from the first identified case to today.
Well, good morning, everybody, and thank you for allowing me the privilege to be able to speak to all of you today. What I'm going to do is try to give you a quick overview of the entire year in review of what's happened with COVID, trying to catch us up to where we are as close to today as possible. I am going to share a presentation with you so that you may follow along with me, and hopefully everybody is able to see my screen right now. And if you can give me a nod or a thumbs up, perfect. Okay. So this is the outline of the things that I'd like to cover, and hopefully at the end of the presentation, we'll still have a few minutes for some questions, as I'm sure some of the things that we're going to cover are going to generate some interest. I will warn all of you that the information we're going to share is not all great news. So if you're waiting for a happy ending, I'm not sure that I'm going to have it, but hopefully some glimmers of hope at the end. So this is the timeline of where we've been. We had the first reported case, hard to believe, still less than a year ago, of a new virus in China around December 31st of last year. And the first death came reported again out of China January 11th. You fast forward just a month later from the first case, and we had the first reported incident here in the United States in January 20th in Washington. And later on that month, the WHO declared it as a true health emergency with the number of cases that we were seeing developing. In February 11, it's where we coined two new terms, really, SARS-CoV-2 and the illness known as COVID-19 that has become now part of our daily vernacular. Our first death was later that month on February 29th, unfortunately, and really was just the first of so many that we have all seen. We first had an Ohio stay-at-home order in March 23rd, which was really instrumental to the early phase of control here in Ohio. And we saw that just a few weeks later, the path of the virus worldwide continued, where we hit 1 million cases on April 2nd. And if you look at the timeline in here, it was only about 4 months that elapsed from that first case until we hit 1 million. You're going to see that timeline really compressing as we move through the year. The US reported, again, just about 4 months later from the first case, the millionth case here in the United States. And then by the end of May, we had really reached 100,000 deaths and 2 million cases by the time June came around. Later that month, the number of cases had gone up to 10 million. Now, in 6 months, we really went worldwide from the first reported case to 10 million cases. That is incredibly fast in a replicating cycle for a virus. And then by July 23rd, the US had already doubled the cases in about a month. From June to July, a little over a month, close to 6 weeks, we really doubled the number of cases we had here. Worldwide, we doubled from our 10 million to 20 million, again, in a little less than 2 months. 200,000 deaths were reported in the US by September 21st. And that was shortly before worldwide we hit 1 million people that had succumbed to COVID-19. By October 16th, the US reached its 8 millionth case and 40 million cases worldwide. And just this past weekend, here in the US, we hit 11 million cases. So if you look between the months of January to November, we went from 1 case to 11 million cases, and now over 200 deaths. And this is really the timeline of what has happened worldwide. And as we look, we want to take a look back and see what have we learned about this pandemic with these 50 million or so cases that we have seen around the world already. And the thing is, we've actually learned quite a bit, and it's helped us to really start changing where we are with respect to the virus. We've learned how this is transmitted. It is mainly respiratory droplets, although in some very specific situations, smaller aerosols can also be part of the transmission. We've also seen that the surface contact appears to be less important than we all worried about up front. So really, it's that person-to-person transmission that seems key. We've also learned a lot about the structure of the virus. And this is a depiction of what the SARS-CoV-2 virus looks like. It's identical to the previous SARS-CoV that we saw in 2002 to 2003. And what I want to highlight are these little yellow spikes that you see around the outside. These are proteins that are key in how this virus really enters the body, because it binds to the receptor for this enzyme, ACE, the angiotensin converted 2 enzyme, that allows it to really enter the body. This is key, as you'll see later on, about how we can start fighting off this virus. It's believed that this really began, as many other viruses do, as a zoonotic virus, which means it is a virus that lives in animals, and at some point it jumps from animals over to humans. And it appears that it really was bat to human transmission in Wuhan that created this. It's very similar to some of the other coronaviruses. However, we still keep hearing that this may have been a weaponized virus that came out of a biological lab somewhere in China. There really has not been any evidence to that, and it's been refuted numerous times, including within the intelligence community within the United States. We also know a lot about what COVID-19, the actual illness, looks like. The majority, the overwhelming majority, over 85%, are going to have mild to moderate symptoms, very similar to what people experience with an influenza-like illness. It's going to consist of things like fever, malaise, muscle aches, cough, and sore throat. That tend to be the most common symptoms. And a few others are going to have some gastrointestinal illnesses, the loss of taste and smell that is very specific. And yet a few others are going to have even less common complaints, like neurologic symptoms that affect the nerves, or blood clots. Most of the people are going to resolve in approximately 2 to 4 weeks, but the people who are having more severe symptoms can actually take months to recover. We also know that approximately 1/3 of patients, and in some studies even higher, could actually be asymptomatic and not demonstrate any symptoms. This is why this is such a hard disease to identify among the entire population, because so many people do not have symptoms. But we've learned that this isn't just a respiratory illness. If you think back to where this all started, it was a respiratory virus. That's what we all latched into, the coughing, the shortness of breath. As we've gone through the year, we realize that this affects the brain. It can cause strokes, that are those so-called COVID brain, which is that fog that people experience. It can cause pneumonia. It can also cause ARDS, which is that inflammation within the lungs that in many cases progresses to respiratory failure. And in some cases, it can cause fibrosis, and that's scarring of the lung that can lead to permanent damage. It can affect the kidneys. It can also affect the intestines, as we mentioned. And in addition to causing blood clots in our arteries, it can cause skin changes, or those so-called COVID toes. And because it affects people in such a different spectrum, unfortunately, some people can succumb from the disease. And we know that it kills approximately 1 to 4% of individuals who get the disease. And the reason that number has such a wide range is because there appears to be a big difference by country regarding the mortality. And here in the US, the mortality is actually in the lower end, closer to the 1%, but also very significantly by what group or what category of individuals we're looking at, with older individuals and those with higher comorbidities having a much higher rate of death. And in some studies, we see that patients over the age of 80 are actually seeing that anywhere from 70 to 80% of those individuals could actually die when they get COVID disease. When we look at just hospitalized patients, patients that are in that 15% or so that get more severe illness, approximately 10% of those individuals do not survive to being discharged from the hospital. And I put this line in here that everybody who died from COVID-19 died from COVID-19, whether the direct cause of death was COVID itself causing organ failure or COVID triggering an underlying condition. It's really COVID that is responsible for most of those people, actually the large majority of those deaths that we see in the hospital associated with COVID. When we've looked at the numbers, it's only about 2% of patients who died with a diagnosis of COVID that may have had a secondary etiology contributing to them. But we also know that it's about 2% of people who die from COVID who we never recognize as having COVID. So the numbers really become almost a wash. The other thing we've learned is that prevention is the most important thing we can do with COVID. Social distancing is incredibly important because as we talk about droplets being the mechanism by which this is transmitted, the farther apart we are, the more those droplets disperse, and it reduces the chance that we're going to become infected. We also know that face coverings are incredibly important at preventing this disease from being passed from one person to the other. Hand hygiene remains important, particularly when we are coming in contact with others. And the need to make sure that people change their perception about what to do when they're ill. Most of us are used to coming to work when we have some mild respiratory illness, perhaps even a low-grade fever. We've learned that because it is so difficult to tell this apart from other illnesses, on symptoms alone, if you are sick, you really need to be staying home. And we also know that avoiding those who are ill further lowers our risk for getting infected. Going back to the issue of masks, we know that masks and facial coverings work. They reduce the spread of droplets. They reduce transmission by as much as 70%. That is incredibly high for something as simple as wearing a mask. We know how important this is. Yes, there is a difference between wearing masks and other facial coverings, but that really becomes important at the point of care for healthcare providers, people who are having ongoing care delivery for those with COVID. It becomes important. For the general public, it does not. Facial coverings really do work. And we know that part of the reason we're in that upward trajectory right now is the recent spikes is because poor adherence to this use of masking. It is important that when we use a mask, we use something that completely covers the nose and mouth. We need to make sure that we avoid all of these pitfalls. The neck scarf does not work at protecting COVID, nor does the guard over the forehead. My favorite is the chin diaper. This does nothing except catch a lot of secretions that can then be transmitted to everybody else. And I still have no idea why people may do this. You see this often when people are drinking or when people are eating. Take the mask off for those situations. It becomes a lot easier to be able to manage the mask. But the other thing is we've learned a lot about treatment. And we know that initially we started with supportive care. There was nothing that we could do for these patients except support them as much as we can and hope for the best. Throughout the year, we've learned quite a bit about what works and what doesn't. And we now have several things in our armamentarium that helps us be able to combat this disease. Remdesivir, which is the antiviral therapy that was rolled out earlier this year, has some data, especially when we use it earlier in the disease. We've used things like convalescent plasma, where we can extract the serum, or it's that non-cell containing portion of blood from people who have recovered, and utilize dose antibodies to kickstart an immune response and help those that are infected. One of the most exciting developments is monoclonal antibodies, and I'm going to come to that here shortly again. And we've learned that steroids are very helpful, particularly in patients that require oxygen therapy as part of their COVID treatment, and it can help them get out of the hospital sooner and perhaps even reduce mortality. Just as much as we've learned about things that help, there are things that have been talked about but have no benefit, things like zinc, vitamin D, and vitamin C. But because these have limited benefit, but the harm is not really there, they're still often utilized in many cases. But from a medical standpoint, these are not things that we widely recommend using, but we also don't prevent people from utilizing. There are also things that we've identified have no benefit and potentially harm. Things like hydroxychloroquine and azithromycin, when used for COVID directly, do not have any benefit and could actually lead to more problems than benefit. Antibiotics, however, in cases where there is a bacterial superinfection, should still be utilized. Two of the newest things in our treatment modalities that are very exciting are the monoclonal antibody therapies. And the most commonly referenced ones are the Regeneron antibody cocktail that has been utilized for some time as part of investigational therapies in both the inpatient and the outpatient areas. We've been using it as part of studies here at Premier as well. And the best data appears to be in the outpatient, where we're looking at patients who have not yet hit that severe illness course, have not been hospitalized. And the data appears to help to show that these drugs help speed up recovery and keep people out of the hospital. And most recent, bamlanivimab, which is one of the other monoclonal antibodies, has received emergency authorization for use under the FDA, allowing us to be able to utilize this drug in the outpatient. You will likely be seeing this starting to get used in our community in the next week or two as we start receiving our shipments of these drugs that just became available to Ohio. What these do is they reduce severity and time to recovery. And I'm going to try to very quickly highlight how this works. So going back to the structure of coronavirus, when we get exposed, all of us will, as part of our ability to fight off an infection, generate antibodies that block all of those little spikes that we said were key to the cell entering, or to the virus entering our cells. These antibodies not only help block the infection, but also help our immune response to clear the virus. When we're using monoclonal antibodies, what we're using is antibodies that are generated in a laboratory, often from other human extraction or from animal extraction, to then be able to bottle up these antibodies and inject them into somebody to be able to fight off the virus by blocking those spots on the virus, and then in fact preventing attachment into the cell and activating of the inflammatory cascade. This is a tremendous possibility to really be able to change the curve for anybody that gets this virus. So where are we today, despite all of this we know? Well, unfortunately, we're not in a great place. Worldwide, we've crossed over 55 million cases and now 1,300,000 deaths. In the US alone, as I mentioned, we've surpassed 11 million cases, and there are presently 76,000 Americans hospitalized. Here in Ohio, we are over the 300,000 threshold for cases and over 3,600 patients today that are hospitalized. We're going the wrong way. And if you look at these curves, the top curve here shows from the beginning of the pandemic to where we are today, the trend in the United States. And you see 1, 2, 3 discrete spikes in here. And then when we look at Ohio, for the first and second spikes, we were actually relatively flat. We did great here in Ohio about slowing the cases. But if you look at this most recent spike, we're actually at a faster rate than the rest of Ohio, which explains why we are seeing this crunch of cases right now. And as we look at one of the things that gets thrown out, we're seeing more cases because we're testing more. That's not really the story. When you look at the number of cases, the number of tests we've done, yes, we're testing more, but we're getting a much higher rate of people being positive. 12.8% of individuals who test right now are positive for COVID, comparing to where we were towards the end of September, down below 3%. This is a tremendous increase in cases and explains why we are feeling this crunch right now. So it's no surprise that at the US level, we are seeing the highest cases that we have seen through the entire pandemic. And locally, we're breaking records almost daily. At Ohio, we've seen almost a quadrupling in the number of cases in some areas, which is putting a big crunch into the hospitals. And many of us are having to start to enact some of our contingency plans. One of the saving graces is that PPE is much more stable now than where we were in the spring. We're also in a totally different place with testing, where we can now get testing turned around in less than 24 hours for most patients. The place where we'd love to be able to go is better and faster bedside testing, and slowly we're starting to catch up, but PCR really remains that gold standard. One of the newer developments that you're all very excited about, and we all are, is vaccines. And compared to where we were just at the beginning of the month, we now have 2 vaccines that are really expected to be receiving FDA approval for emergency use by the end of this month or beginning of December. These are 2 mRNA vaccines, which means they have a little bit of genetic material from the virus inside, and when injected into the body, generate an immune response. They both require 2 doses, but both are over 90% effective when compared to placebo. That means that 9 out of 10 people who get this vaccine will not be ill from the virus when they get exposed to it. That is a tremendous response, and probably better than what we see year in and year out compared to our influenza vaccine. And there are a lot of reasons for that, but this is a great place for us to be starting. The thing we have to keep in mind is, while this will be ready for approval, hopefully by the beginning of the next month, the delivery of these vaccines are going to take some time. And even as we start rolling things out, it will likely be 6 to 12 months before we have enough people vaccinated to really start extinguishing the disease, which means all the preventative things that we have in place are likely to be needed through most of next year. And there's still a lot of challenges for vaccine, like acceptance of a vaccine and how we store it, how we distribute it. You've heard a lot about cold storage and the super cold or the ultra cold refrigerants that are required. It is not as much of an issue with the Moderna vaccine as it is with Pfizer, but that's something that, again, needs to be considered when we look at our vaccination strategies. The other question that still has to be answered is, how long does our immunity last? We know that when we have infection or vaccination, we have immunity. What isn't yet clear, is it a lifelong immunity, or is it an immunity that only lasts for a little bit of time? And the reason that that becomes very important for us to be able to answer is because it'll determine how long this virus will be around for us to be able to fight. The reason we don't know this is, again, the virus has only been around for less than a year for us to study. The best data we have is 11 months worth of data from people from China that have become infected before. We believe that the immunity will be long lasting, but we still have to be able to prove it. So the big question is, what happens next? This is where we all go to our crystal ball and try to prognosticate. In all honesty, the outlook for the next couple of months is not great, particularly the next 6 weeks. Cases are going to continue to go up, and they are going to be peaking sometime between the beginning or middle of December. The estimates that we had is a doubling of the cases that we had last week by that point, and we are on pace to get there. It's important that everybody recognizes that, because we need everybody to understand why we are tightening up, why we need everybody to really adhere to a lot of the skills, to adhere to a lot of those techniques for prevention. It also means that in many areas that don't have a lot of resources, people may be starting to see some hospital access issues again. And it's important to be able to recognize that. It also means we're likely to see more restrictions moving in. And you just saw that starting tomorrow, we're going to be having some of those already enacted. I would be surprised if that was the last of the restrictions that comes out, unless we make some major turn in the trajectory we're headed now. Looking farther ahead, 3 to 6 months, we're likely going to be seeing some intermittent peaks and a need for masks, but I believe we're gradually going to be seeing that curve downtrending, especially if we're really able to leverage things like vaccinations and newer therapies. But beyond that, we don't know. We don't yet know if this is a virus that is going to become seasonal or is going to be with us for the duration. And that's because we don't know all the pieces related to immunity just yet. So what are the things that we have to do moving forward to succeed? Number one is we got to stick to the current recommendations for prevention. Right now, this is our best shot of containing this virus, is we got to prevent passage from one person to the other. It unfortunately means we're going to need to limit those holiday gatherings. If there is anybody who doesn't yet believe that that is the key, I'd be happy to talk to you in detail. That is where we're seeing the biggest growth, where we are letting our guard down because We don't perceive as family as a threat. And unfortunately, there are way too many examples of those situations where a birthday party or that one time going to see mom and dad turns into perhaps the last time we get to see mom and dad because they got the virus. We've got to recognize that. That's one of the ways that we can really start making a difference. We need to make sure that when the vaccine rolls out, we get wide acceptance, which means we need to understand it and we need to have healthcare professionals delivering it and promoting it once we know all the full safety data. And both of the vaccines that we're seeing right now look like they are indeed safe. Doesn't mean that they are without side effects, especially localized reactions, but they are safe for use. We're going to be seeing newer treatments, and we have to make these more available to more people earlier in the disease course. So we don't have to wait till people have to be in the hospital. And this is where the monoclonal antibody therapies are really headed, which is to the outpatient area. We need to also follow the science as we learn more about this and understand the immunity effects. We need to know how long immunity is going to be able to hang around. And that's really the only way that we're going to be able to get a handle on COVID-19 and start getting things turned around. Hopefully, I've been able to give everybody a not too scary view of where we have spent the past year with COVID-19. I'd be happy to entertain any questions at this point.
I have a question, Dr. Colon, if you don't mind. And it's concerning the masks. I was a surgical technician for most of my career, and you know, I know the reason I wore a mask in surgery. Obviously, you know that as well as I do. But it was also to protect me from people that may have been addicted to drugs. You know, I went through that period of time when there was the HIV syndrome, the hepatitis C. So, you know, I also wore a mask to protect myself from them. And, you know, I see a lot of people out and about, number one, that aren't wearing masks. And so I don't, obviously I know your feeling on that, but what, you know, and the other thing is I know there's a lot of ingenuity going on right now, making your own masks and things like that. I wear an N95 mask because of the material it's made of. My feeling is some of the masks that people are wearing now, they're cloth. As soon as you put them on, you know, within a 5-minute period, with your breathing, sometimes coughing or sneezing, it's already saturated. And that to me, it feels like it's already compromised. So, you know, what's your feeling on a specific type of mask that we should be wearing, if you have any at all?
That's a great question. So when we are wearing PPE for self-protection, and that's where we're using it in the hospital, where we're using it in a surgical location, not only are we preventing our respiratory droplets or other things from going to surgical field, we're also preventing, as you highlighted, fluid from getting us infections. And when we look at surgical areas, we're really preventing fluid transmission, not necessarily a lot of the other things that we think about, like a virus that may be passed through respiratory droplets. In reality, there is not a need for most people to wear an N95. And the N95s are really required only in those situations where you're going to be exposed to aerosol generating procedures that have more of those tiny little droplets that can travel farther through the air and get through the mesh of fibers.
Okay.
When we look at general masks, including cloth masks, there are differences about what we're trying to accomplish. A cloth mask by itself is not going to be as good at preventing me from getting an infection from somebody else that has full respiratory droplets coming at me without any protection. And that's why we don't recommend cloth masks at the patient's bedside for direct patient care. However, when two people are wearing cloth masks, what these masks will do is they will create a barrier when my respiratory droplets are expelled, where they won't travel nearly as far. It slows down the speed, so they quickly fall to the ground. And they do a great job about absorbing a bulk of those respiratory secretions so that they don't go out. But you did highlight a big point that people often forget, which is if my mask is saturated, I need to change it. If my mask is soiled, I need to change it. So if you are wearing a cloth or other mask for the entire day and your job requires to be speaking a lot, you're probably going to have to change that 3 or 4 times a day. That would offer a better layer of protection, because once you get that mask saturated, then what it does is it actually can bring in secretions from the outside as well. And now instead of protecting me, it could get into a situation where it could increase the risk associated with wearing it. So that's a great point that we always need to highlight, is you wear a mask until it is saturated or soiled, and then you need to change it. But there have been studies that have looked at any of these cloth or homemade masks, and they actually have very good data about reducing the spread of droplets by as much as 90% in some cases. And it's a double layer cloth is the ideal.
Thank you very much. I
You are
appreciate
very
that.
welcome.
Yeah. And just, if you don't mind, I have one more question. I was listening to WHIO radio this morning, and I don't know if I heard this wrong, but they mentioned that Premier Medical Center is getting some of the first doses of the vaccine. Is that correct?
Well, I think we are working to make sure that as soon as the vaccine is made available, that we're going to be up and running to be able to administer it. I have not heard any of the distribution being ready to go out for anybody yet. The way that the first vaccines will actually be working is you will see them being distributed to the State Department, not to the State Department, sorry, to the state health agencies, and then being distributed and allocated that way until they become much more available and can be obtained directly from the company, similar to how other drugs may be available. This is especially important when you have any drug or any treatment that's not truly FDA approved, but it is FDA emergency use authorized. And that's how we've been using things like remdesivir. Actually, remdesivir is now FDA approved, but we've been using other therapies under emergency use, and convalescent plasma is one of them. The same with this monoclonal antibody, where they're very tightly regulated with how they're going to be dispersed.
Thank you very much. I appreciate that.
No problem.